Welcome, everybody. I am Molly Brown from the Heartland Telehealth Resource Center. We're glad that you're joining us today for the education series focused on telehealth billing, coding, and policy. Just a few notes as reminders. This session is being recorded and we'll share it with you afterwards. Your microphones have been muted, so please use the chat box to ask questions as we tend to have a large group during these sessions. If you would like a completion certificate, please contact us at htrc.kumc.edu. We will put the email address in the chat box later. Be sure to include your full name as you would like it to appear on the certificate. Again, we are not automatically sending these out any longer just simply because our groups are so large. But if you do need one, please email us and we'll get it to you as soon as possible. So let's get started. I'd like to introduce Richelle Marting. Richelle is a local attorney who is also a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing, and reimbursement, HIPAA privacy and security, health information management, and regulatory compliance. We're thrilled to have Richelle with us today to take a deeper dive into codes used for reimbursements. Now I will turn it over to Richelle.
Thank you. 3 topics that I want to do a deep dive into today. And these came about as in our last couple of sessions, we talked about some new coding and policy that has been released by Medicare for the 2024 physician fee schedule and professional services that were newly created and covered for this year. So that's topics number 2 and 3, a new separate payment for certain providers when they perform a social determinant of health risk assessment. We'll talk about what this new service, this new benefit is, I should say. The service has been there and Medicare recognizes the services have been provided, but the value of those services have not been adequately captured through evaluation and management or other codes that are currently available. We'll talk about what is encompassed in this new separately payable code and benefit under Medicare called the Social Determinant of Health Risk Assessment. We'll also talk about a principal illness navigation code. We touched on this service when we talked about the physician fee schedule for 2024, but I wanted to dive into it even further to make sure that we covered all of the required elements, discuss what the service is and how it can be billed and paid for under the Medicare program. Our first topic of the day is taking a step back to, I don't want to say back to the basics, but a little bit talking about new patients and established patients. And the reason I'm taking a step back to cover this sort of foundational concept is that a lot of our care management services in the Medicare program, like principal illness navigation, community health integration, behavioral health integration, chronic care management, transitional care management, even remote patient monitoring are services provided to established patients. And some rules changed beginning in 2023, both from a CPT coding perspective and also clarifications from a Medicare perspective on when a patient is a new patient, when a patient is an established patient, and that distinction then guides us into when we can begin billing for services like social determinant of health risk assessments, principal illness navigation, and other care management services. And spoiler alert, the definitions of a new patient and established patient under CPT rules are not the same under the Medicare program. So that's where we're going to start. So we're going to start with the CPT definition. And when I'm saying CPT definition, this generally would also be the rule that you would apply outside of the Medicare program to your commercial payers. But whether your commercial payers or other payers outside of the Medicare program follow these CPT rules and definitions for a new versus established patient, or Medicare's rules and definitions for new versus established patient might very much depend on your own individual contract with those payers and any policies that they have defining whether they follow Medicare or whether they follow CPT. So this is sort of our default unless a payer contract or the Medicare program says that they follow Medicare's rules, and those rules are going to be different, as we'll see in a minute. So just starting with the CPT is sort of our default. See, in the CPT book, in the guidelines, before the evaluation and management codes even start, there's a definition of what constitutes a new patient versus an established patient. And a new patient is one who has not received professional services from the physician or another provider of the exact same specialty and subspecialty within the same group practice in the last 3 years. There's a lot of really important pieces to this definition to break down. What constitutes a professional service? Because if there has been no professional service from that provider or another provider of the exact same specialty and subspecialty to that patient within the same group practice in the last 3 years, that's a new patient. What constitutes the exact same specialty and subspecialty, and what constitutes a group practice? So let me address a couple pieces of that definition here. Specialty and subspecialty. When I'm looking for a provider specialty and subspecialty, there's a couple of places I would look. First, I tend to use that provider's NPI number. And I go to the NPI number registry to look that provider up. And I scroll all the way down to the bottom, and there is a listing of how that provider's national practitioner identifier number has been classified in terms of specialty and subspecialty. That's one way. But from a payer perspective, for commercial plans, if you have a contract with that payer, specialty and subspecialty will depend on how you have credentialed a particular provider with that health plan. How have they assigned the primary specialty versus subspecialty? And that's really important because that's going to distinguish whether multiple providers have the exact same specialty and subspecialty designation, which then dictates new and established patient code assignment. Give you a couple of examples. There are specialty taxonomies for family practice, but there's a different specialty taxonomy for general medicine, for geriatric medicine, for peds, for internal medicine. So all of those could be different primary specialty designations. And then within each specialty, providers can have a designated taxonomy under their NPI number or as they're credentialed with particular health plans, identifying their subspecialty within that practice. So CPT will recognize different subspecialties down to that level of granularity. And if the subspecialty is different, if the primary specialty is different, even between general medicine and family practice, those are different specialties that could allow patients seeing providers among those different specialties to be treated as new patients when they see a provider of a different specialty. So group practice. The simplest way I can define group practice is by tax ID. So in the Kansas City area, I always think of our health systems and that a single group practice might have many, many, many locations throughout the metro area. We might have 15, 20, 25, 30 different physical location and clinics that a patient could present to. That physical location does not dictate whether the patient is new or established. They could be presenting to a building that they have never been to before. But if that building is part of a group that all has the same tax ID as a group practice, that patient can be an established patient, even though they've never been to that location before. If they've been seen by any other clinic within that group practice, within that tax ID, they could be established if they've seen another provider of the exact same specialty and subspecialty under that tax ID in the last 3 years. So now I'm going to go back to the first part of this definition. What's a professional service? And solely for purposes of defining whether a patient is new or established. Under CPT, a professional service means a face-to-face service, which can also be done via telehealth. It doesn't have to be in person, but a face-to-face service rendered by a professional who can report E&M. This definition alone has a couple of components we need to zoom in on. So face-to-face, again, is not the same as in person. A professional who can render E&M is a physical therapist, for example, who cannot report evaluation and management services, but who might be a professional under our tax ID. And if a patient has seen a physical therapist face to face and then comes to see one of our primary care providers, that patient can still be a new patient with primary care because they've not seen a provider of that exact same specialty and subspecialty in 3 years within our group practice. Even though they've had a face-to-face visit, for new and established patient purposes, a visit with the PT is not considered a professional service because the PT cannot report E&M. I want to talk about the face-to-face piece just a little bit more as well. This actually came up in a discussion I had this morning with a clinic, and they were asking about a denial for a new patient visit. First time the patient had ever seen that particular provider, but a year ago, the patient had had an EKG, and that's the only service that had been billed previously. And we were talking about whether that EKG is a professional service. Number one, was it face to face? And the technical component of that service, like where the patient was actually hooked up to the monitor and the EKG was taken, that was a professional service billed by a provider, by a physician who can report E&M and happened to be in the same specialty as the provider who was seeing the patient for the first time when we reported an office visit E&M. I don't know why there wasn't an E&M previously. However, the patient met the definition of an established patient, even though it was the first time they'd ever had an E&M by any provider under that group practice, under that tax ID. So I'm still under CPT definitions, and there are some additional clarifications that CPT made last year, effective January 1 of 2023. And last year, CPT, which is published by American Medical Association, so CPT AMA says a provider who is on call for another professional, they're sort of stepping in the shoes of a professional. Think of locum tenens, think of a provider in a practice who's covering for another professional while that professional is on vacation or otherwise unavailable. That provider who's covering, who's stepping in the shoes of a provider who's absent, assumes the specialty and subspecialty of the provider that they're covering for. So if in our clinic we have an internal medicine provider covering for a primary care provider, and a patient who usually sees the primary care provider today sees the internal medicine provider, that's not a new patient visit under CPT rules because that patient has not seen a provider with that same specialty in that group practice in the last 3 years. Or I'm sorry, back up. Under CPT, it is an established patient because the specialty of the internal medicine provider is assumed to be the same as the primary care provider that they're covering for. Sorry for that misstatement. I gave you the Medicare rule, not the CPT rule. Let me say it one more time to make sure I'm not mixing it up for you. When the patient comes to see the internal medicine provider, who is covering for primary care. Under CPT rules, that is an established patient visit because the internal medicine provider is assumed to have the same specialty at that time. They're covering for primary care, so they're acting as primary care. And so they have the same specialty and subspecialty as a provider that patient has seen within the last 3 years. Sorry for that. Under CPT, I want to also clarify that advanced practice providers, a physician assistant, a nurse practitioner, they are also considered to have the same specialty as the providers with whom they are working. So if a patient sees a primary care physician and then sees an advanced practice provider a few months later in that same group, that's an established patient visit under CPT rules with the advanced practice provider because they are assumed to be working in the exact same specialty and subspecialty as the physician with whom they're sharing a practice. Now I'm going to flip to Medicare because Medicare is different in several ways from CPT rules. Under Medicare's rules, these aren't new necessarily, but Medicare reiterated several of these rules last year in the physician fee schedule. In the Medicare program, a patient is new if they have not seen or if they have not received professional services from a provider of the same specialty in the same group in the last 3 years. Professional services has the same definition as CPT. So check that box. That's one place where Medicare and CPT align. Professional services are face-to-face services. A non-face-to-face service like an e-visit, like a virtual check-in, those would not automatically disqualify a patient from being considered a new patient because they're not face-to-face. Telehealth can still be a face-to-face service. Provider of the same specialty. Medicare does not recognize subspecialties. So when providers are completing their enrollment form under the Medicare program, the 855I enrollment form, and they're identifying their specialty for Medicare, Medicare doesn't allow providers to choose subspecialties. So family practice or internal medicine might be a better example. Some providers might have a subspecialty of endocrinology. Under Medicare, that subspecialty that they might be enrolled as in other programs is not recognized. It's however they're enrolled in their primary specialty. And if those are the same among providers, then patients might be established patients within the same group practice within the last 3 years. Now, a difference between CPT rules and Medicare rules for advanced practice providers is really important. Under the Medicare program, advanced practice providers enroll on the 855I enrollment form as their own taxonomy, as their own specialty. And so they are considered to be a different specialty than the physicians with whom they are working. So if a patient sees a primary care physician in the Medicare program and then sees a nurse practitioner a few months later, that can be a new patient visit with the nurse practitioner, even if that same patient has seen the physician in the same group practice in the last 3 years, even if the advanced practice nurse practitioner and the physician are both acting in a primary care capacity. The challenge with that is all advanced practice nurses, all physician assistants are considered to be practicing in the same specialty. So in the hospital setting, You might have advanced practice registered nurses who are working in cardiology, who are working with hospitalists, who are working in pulmonology or critical care or anesthesia. Or I guess anesthesia may not be a good example, but critical care medicine. Because all advanced practice registered nurses, all nurse practitioners enroll as the same specialty with Medicare. Patients receiving services from different APRN specialists will be considered established patients if all of those specialties are billing under the same group practice. Same for physician assistants. Even if they're working in different PA specialty areas, PA is one specialty with Medicare. And if a patient has seen a physician assistant billing under the same group practice as another PA that patient has seen in the last 3 years, regardless of the service line, that can still be or would be an established patient for that patient under Medicare rules. We talked about Medicare not recognizing subspecialties. So all of those rules are used to help us decide if a patient is new or established. And for Medicare purposes, we want to be looking at whether the patient is new or established because certain care management services, now that the PHE has ended, and the flexibility to provide care management to new patients has gone away. Now there has to be an established patient before we provide certain care management services. So we'll follow Medicare's rules in deciding whether the patient is established to provide care management to a Medicare beneficiary. So now I'm going to switch gears a little bit and talk about a new payment benefit effective January 1 of 2024 under the Medicare program called Social Determinant of Health Risk Assessment. And certain providers can now receive separate payment when performing an SDOH risk assessment for patients. And this is when you're assessing for educational, developmental, environmental, housing, other personal factors that might influence our plan of care for a patient. And I liked this quote in the physician fee schedule that this is from CMS. We've sought to recognize significant changes in healthcare practice and have been engaged in an ongoing incremental effort to identify gaps in appropriate coding and payment for care management, coordination, and primary care services, one of which CMS identified that there was a gap was in risk assessments for social determinants of health. So we're going to talk about what this benefit is, what this separately payable code now describes. And this is another quote from the final rule, recognizing that the practice of medicine has been evolving, and that CMS is trying to recognize the importance of these activities in the evolution of medicine, one of which has been screening and or assessing patients for SDOH risk factors. And while we collect social history as part of an evaluation and management service, CMS believes that social determinants of health is really separate from the social history that's collected for a patient as part of an evaluation and management service, and believes that that work to assess those SDOH factors is not currently recognized or taken into consideration in the value and the payment for evaluation and management services. That belief prompted the development of a new code to be paid separately this year under the Medicare program. So what I've got on the screen now, this is a screenshot of the new AMA CPT medical decision-making table on how you determine the level of medical decision-making, the level of service, the code assignment for evaluation and management codes. And CMS talks about this when they were creating this new social determinant of health risk assessment code that went into effect this year. And they highlighted that this is even taken into consideration in the complexity of an E&M visit. If our diagnosis of the patient or our treatment plan for the patient is significantly limited by the patient's social determinants of health. And CMS said there's only one way we can figure that out, and that's by assessing social determinants of health. And we need to capture that work through a separately billable service that's not already being captured in E&M. So this new code, we'll look at the code and we'll look at the elements and the billing of it in just a moment. But what this new code that can be separately paid in addition to an evaluation and management service was initially thought to help account for some of the services that social workers in the clinic setting might be performing, but that aren't being billed separately because social workers didn't have their own benefit category, aren't enrolled as their own providers under the Medicare program typically. However, this code is not limited to work performed by social workers. That was just sort of the impetus for its development. And CMS says we believe social workers and other auxiliary personnel are currently performing some of these activities, and that these are not consistently and appropriately reflected in our current payment policies. A social determinant of health risk assessment is generally going to be carried out incident to another professional's plan of care. What that means that it's carried out incident to is that we're going to have established patients that we're doing SDOH risk assessments for, usually. The reason for that is under the incident to billing rules, you can only provide services incident to and bill incident to when it's part of a provider's plan of care. So before we even get to an incident to service, there's been a visit with a provider and a patient where a plan of care is developed. And this is incident to that. So typically these are carried out incident to a physician or advanced practice provider's plan of care for a patient. Excuse me. The SDOH risk assessment can be personally performed by a physician or other qualified healthcare professional, such as during a new patient visit. However, they're not valued to take into account a physician and qualified healthcare professional's work. And so the payment would not be commensurate with a physician's time and effort and resources. So you will often find this is going to be carried out by clinical staff or other auxiliary personnel on the physician or other healthcare professionals' behalf. One piece that Medicare really emphasized in the physician fee schedule is that this is a risk assessment. It is not a screening. And what that means is a screening is a preventive service that we're doing without any known identified risks, diagnoses, or conditions. Generally, screening services are paid as preventive, and there's no patient cost sharing for those services. There is patient cost sharing with a social determinant of health risk assessment with very, very limited exception, like when it's performed in conjunction with a Medicare annual wellness visit or initial preventive physical exam. All other times, this assessment is when we have identified certain factors that the patient has shared with us that might be social influences on the patient's plan of care. And so we step back and do a more comprehensive assessment of those risk factors. Because this is an assessment and not a proactive screening, commenters were suggesting that this code could be used and could be paid separate on a different day than an evaluation and management service, that we might deliver a screening tool or an SDOH tool to a patient 7 to 10 days before a visit. The provider takes that into account as the visit occurs. And CMS disagreed with that that practice pattern and said, because this is an assessment, not a proactive screen, we don't agree that this typically would happen as a form that the patient fills out prior to coming in for their visit. And instead, CMS believes that for the most part, an SDOH risk assessment is going to be done the day of an evaluation and management service. So here's a clinical example that CMS gave, that through this risk assessment, the provider discovers that the patient's living conditions are such that they don't have reliable access to electricity. And because of that, the patient with diabetes may not be able to keep insulin that requires refrigeration stored at the appropriate temperature. So that risk factor that has been identified might prompt a risk assessment or could be the result of a risk assessment that changes the treatment plan. The provider might then change the patient's insulin to a type that can be safely stored and maintained at room temperature, or an oral anti-hyperglycemic that doesn't have to be stored in the refrigerator, that's not dependent upon reliable access to electricity. Part of the element of a social determinant of health risk assessment, not screening, assessment, is the administration of a standardized evidence-based risk assessment tool. However, a particular tool is not required. Medicare gives a link in the final rule to some examples, but there is not a delineated list that says you have to use one of these tools in order to bill for an SDOH risk assessment. You can choose any standardized, evidence-based, validated SDOH tool and still be able to report the service and receive additional payment. CMS really emphasizes the follow-up is critical. You don't just deliver the assessment, have the patient fill it out, or have the auxiliary personnel carry out the assessment and then put it in the chart and leave it alone. This is really intended, the separate payment is intended to capture the work to incorporate the findings, if any, into the treatment plan for that patient, like changing the patient's diabetic medicine based on lack of access to reliable electricity. CMS also says that they're putting a frequency limit on this service of once every 6 months because they don't think that typically the patient's social factors would significantly change more frequently than every 6 months. So for coding, this is how we would capture this new SDOH risk assessment service for separate payment on top of an evaluation management service. The new code is G0136, which describes an administration of a standardized, evidence-based social determinant of health risk assessment. There's a time range in here, 5 to 15 minutes of service. So we want to make sure when we are delivering the service that the auxiliary personnel are documenting that at least 5 minutes were spent administering the risk assessment with the patient, reviewing it with the patient, and the follow-up, taking the results of that assessment into account in how the treatment plan is going to be carried out for that patient. From a diagnosis coding standpoint, there's no one particular diagnosis code that has to be linked to G0136. But CMS recognized there are a lot of Z codes within the ICD-10 codebook that might describe some of the findings from that social determinant of health risk assessment that could be, they don't have to be, but they could be used, assigned, and linked to this code from a diagnosis code standpoint. So just kind of looking through the different and the different services with which an SDOH risk assessment should be reported. Probably the most common service that it's reported with will be an office visit code. So 99201 through, or I guess that code's been deleted, 202 through 99215. But the SDOH risk assessment can also be reported by behavioral healthcare professionals. It could be reported with a psychiatric diagnostic exam, with codes for health behavior assessment and intervention services. And so we've got a list of CPT codes there. It can also be performed in conjunction with a Medicare annual wellness visit. This is a Medicare code developed for the Medicare program. So most of the Medicare Advantage plans should also cover this service, whether they cover it in addition to, I guess let me back up, whether they pay for it separately in addition to an evaluation and management service might be a question. You've got to look at your contracts and you have to work with Medicare Advantage plans to determine how they're going to process these claims. Commercial plans can recognize the SDOH code as well for separate payment, but they don't have to because it's a Medicare code. So that would really be contract dependent from a commercial standpoint.
Richelle, before we get too far away from the slides, I did want to pop in. There was a question. It says, will this be a FQHC billable visit? You may need to clarify which visit code that you're referencing. I believe it was attendant gearing.
And probably looking at the G code for the SDOH risk assessment. That's a great question because my answer is going to be different once we get to principal illness navigation. This is not separately billed and paid and reported for FQHCs or RHCs. So this isn't one of the care management services that you could report as a care management code in the FQHC and RHC setting. Principal illness navigation that we're going to talk about next is a care management service that can be captured as a care management code separately from your all-inclusive rate or your FQHC PPS rate in those settings. This code is going to focus on, I hate using the term regular clinics, but place of service 11, a clinic that is not an FQHC or an RHC. Great question.
And then the second question related to these codes is, are they applicable for pediatric patients as well?
Well, so that's a great question. If a pediatric patient was covered under the Medicare program because of certain disabilities, then yes. But pediatric patients who are covered by other health plans, it will really depend on your contract with those health plans and whether they recognize this code. So you could look at that under the fee schedule for your contracts. If your contract is one that is based on a Medicare fee schedule, likely, yes. That could be a separately payable service in addition to your office visits for a pediatric patient. But that answer on the commercial side is going to be very contract specific on how your contract is structured and how your fee schedule is structured for every payer. Great question. So the last piece I want to touch on for the SDOH risk assessment is that it has also been added as a permanent telehealth service for the Medicare program. So January 1, 2024, you could provide the SDOH risk assessment in person on the same day as an office visit, psychiatric diagnostic exam, or any of those other CPT codes that we've listed on the previous slide. Or it could be part of a telehealth service because there is a face-to-face component, whether that's physically in person or through a telehealth visit for the SDOH risk assessment. It is the provider's professional judgment on whether to do this assessment with or without direct patient interaction. However, it's not an add-on code, but Medicare will only pay for the service when it's done on the same day as another professional service. So switching gears a little bit to principal illness navigation. These are new a new benefit under the Medicare program. But to go back to Gary's question, these services are considered care management, even for FQHCs and RHCs, where you can bill a care management code in the FQHC and RHC setting for separate payment in addition to your all-inclusive rate or your FQHC PPS rate. So a principal illness navigation service, or PIN, is the way you'll see this abbreviated in Medicare documents. These can be furnished following and initiating E&M visits. So under the care management umbrella for Medicare, there's always an initiating visit, a comprehensive initiating visit. That doesn't necessarily mean high complexity like a 99215 or 205, but there has to be an initiating visit before we provide and start a principal illness navigation service. And for principal illness navigation in particular, this is for a patient who has received a new diagnosis, um, that a serious high risk condition. The physician fee schedule gave the example of HIV. It could be diabetes. It could be a cancer diagnosis. And the idea with principal illness navigation is we're truly, if you look at the icon on the bottom of the slide, we're truly kind of hand holding the patient and walking them through navigating the health system for this new serious or high risk diagnosis, illness, or disease. To qualify for principal illness navigation, the patient has to have at least one serious or high risk condition that's expected to last at least 3 months, places the patient at significant risk of hospitalization, nursing home placement, acute exacerbation, functional decline, or death. COPD might meet this definition, right? Placing the patient, it's a serious condition. We expect it to last 3 months, places the patient at serious risk of hospitalization or acute exacerbation or functional decline. The condition requires the development of a disease-specific care plan. It might require frequent adjustment. It might require changes in the patient's medication, or substantial assistance from a caregiver. So in this sort of course of treatment for a patient who has a new diagnosis of a serious high-risk condition, there's an initiating visit by the provider. This is usually where that initial diagnosis is made with the patient or for the patient. They bill for that evaluation and management service the same way they always have or they always would. Typically, CMS believes that hospital visits would initial inpatient or observation visits, even ED visits or skilled nursing facility visits would not typically serve as the initiating visit because the practitioner in those settings would not typically be the same provider rendering the continuing care. But that's not a limitation. It is possible that an oncologist in the hospital issuing or having that initiating visit with the patient where the new diagnosis is made may also be the same specialist that the patient follows up with after hospital care. And if that's the case, those settings could be, but are not typically the initiating visit for the principal illness navigation care management episode. Behavioral health integration and other care management codes like chronic care management, transitional care management don't count as the initiating visit. And that's because we have to have the initial comprehensive service that's required of all care management services before we render and bill for principal illness navigation. But there are several newly added services that can constitute the initiating visit for care management. Psychiatric diagnostic exam, those same initiating visits for SDOH assessments can also be initiating visits for principal illness navigation. After that initiating visit, by a physician or other qualified healthcare professional. That's where the diagnosis might be made, where the patient might be introduced to the concept of principal illness navigation, and the disease specific plan of care has been developed or recommended to be developed. Then those principal illness navigation services themselves can be carried out incident to the physician or other qualified healthcare professional's plan of care. Usually it's going to be the same professional doing the initiating visit, billing for that visit as an E&M, psychiatric diagnostic exam or other visit, and then billing as the supervising provider for the principal illness navigation services. So this is kind of a description of the elements for principal illness navigation. So it's services carried out by a auxiliary personnel who have been trained as principal illness navigators on helping the patient, navigate, walk through this new diagnosis. They're under the direction of a physician or other qualified healthcare professional. That's part of the incident to billing requirements. Excuse me. Because to bill incident to a physician or qualified healthcare professional services or plan of care, there has to be direct supervision. Direct supervision under Medicare means those trained auxiliary personnel carrying out these activities are doing so under a direct supervision. They are physically located in the same office suite as the oh my gosh, excuse me, the supervising physician or qualified healthcare professional. Or because these are care management services, general supervision of that auxiliary personnel could also be carried out where the professionals could be contract staff or a vendor helping carrying out these services without being physically located in the same office suite as the physician or other qualified healthcare professional who performed the initiating visit and whose supervision principal illness navigation services are being delivered under. But that initiating provider still has to have the overall responsibility for these services. These are timed services throughout the calendar month. So as auxiliary personnel, clinical staff, or others are carrying these activities out, they need to be documenting their time throughout the month. And once we have once we have reached a minimum of 60 minutes in a calendar month, that's when the principal illness navigation code could be billed. 60 minutes is a minimum threshold. We're not following the CPT default time rule where as long as the midpoint has passed, you could bill for the service, you have to have at least 60 minutes. And we're using a calendar month, not a running 30-day period. So if we start on the 25th of the month and we don't meet 60 minutes before the end of the month, we don't get to bill principal illness navigation for that month. We start anew on the first of every calendar month. And here's some different activities that might be carried out. Who's in carrying out these activities, that time for these services can count towards that 60 minutes. A person-centered assessment, including any unmet social determinant of health needs, which we might have identified through an SDOH risk assessment that have not been separately billed. Understanding the patient's story, their strengths, their limitations, their resources, their goals, their preferences on how they interact with the healthcare system and their plan of care. Building advocacy skills, health education, these are all examples, but we don't have to deliver each and every one of these items in order to bill for the principal illness navigation services. Now I've got one of these crossed out because helping the patient navigate the healthcare system was a required or was proposed to be a required element for this service. And in the final rule, CMS said that can still happen, but it's not a requirement that you do this particular activity as part of your 60 minutes in a calendar month in order to bill for principal illness navigation services. So here's our coding for principal illness navigation. We've got principal illness navigation G0023. So I've got that code on one of our slides, or I'm not sure why I don't have G0023. That's our code for the initial 60 minutes of principal illness navigation in a single calendar month. If we exceed 60 minutes for each additional 30-minute increment in a calendar month, we can report G0024. Now, let me back up for just a little bit because Gary, you asked the question specifically about FQHCs and RHCs. So hold them separate. So hold that thought for just a moment because these are the codes for a regular clinic setting. And we can report G0023 for the initial 60 minutes, G0024 for each additional 30-minute increment of services for a single patient in a single calendar month. There's services for peer support by a certified or trained auxiliary personnel under the direction of a physician in 60 minutes per calendar month, and each additional 30 minutes by that peer support specialist in a calendar month. Go back to the coding really quick before I forget. For FQHCs and RHCs, principal illness navigation services are among the services that have been added to the list of care management services. So you report your G code in the FQHC and RHC setting that you report for any care management services rendered to a patient in a particular calendar month. And for this year, the way those services are paid has been recalculated a little bit. Last year and in previous years, the codes for care management in an FQHC or RHC setting were paid, or the rate was defined as an average of all of the individual services that could be billed as care management. So that could be chronic care management, transitional care management, principal illness navigation. And Medicare used to just take the numbers for each of those services that are eligible to be reported by FQHCs and RHCs as a care management. The average was your number. But this year, Medicare recalculated or is implementing a new formula, and it's a weighted average. So Medicare looked at how often chronic care management is the service under, or how often chronic care management is being reported under fee-for-service providers. How often is transitional care management being reported? How often is behavioral health integration and other care management services being reported under fee-for-service Medicare? And by taking a weighted average, that's how the new rate for care management codes for FQHCs and RHCs will be determined. And effective this year, remote patient monitoring, RPM and RTM codes were made a part of that calculation as well. Okay, so general billing, and I'm kind of flipping gears back to fee-for-service providers who are not FQHCs or RHCs. Medicare initially proposed a frequency limit for the services described by each additional 30 minutes or a reassessment or principal illness navigation support. Medicare did not finalize a frequency limit for reporting those services. But there must be an initiating visit, a new initiating visit, at least once per year for patients who are receiving principal illness navigation services on a monthly basis. All auxiliary personnel have to be certified or trained. So they don't necessarily need to hold a particular credential, but you should have evidence that they have been trained in how to carry out principal illness navigation services. We need to document our time in the record because these are time-based codes to be able to support that we've rendered at least 60 minutes in a calendar month. And that's regardless of whether you're a fee-for-service provider, FQHC, or RHC. You all would need to show you've met the requirement to bill principal illness navigation. And then which code you bill depends on your provider type. Okay, I'm going to pause there because Molly, I know you have a couple final announcements, and see if we have any questions in the chat that I can help answer before we wrap up on time.
Sure, there's just a few, and we have been, letting everybody know we can always get them as part of the follow-up too. Just a couple clarifications. The social determinants of health risk assessment is only for telehealth with audio and video rather than audio only.
That's a good, let me go back and double check the telehealth list. Medicare in the telehealth list for this year, fortunately, brought back a nice format that tells us which codes can be rendered as audio only. So let me double check that, and we can get that out after the session, whether that it can be delivered, whether it must be interactive audio visual, or if that code can be reported in an audio only format. Great question.
Okay. And there was a secondary one to that related to Medicare will pay for the SDOH risk assessment on other days than the E&M code or visit.
That's a great question because it is a standalone code. It's expected to be performed with an E&M. My recollection was that it had to be the same day, but let me double check and see if there were any caveats or exceptions, as long as it is in conjunction with a billed E&M psych diagnostic exam or those other services. I believe it's the same day, but I will verify, and we can send that out to be certain.
And then there was an auxiliary certification and training question. I believe you answered it, but we'll go ahead and answer it again in our follow-up. We've copied that one. And then one final question that we can get to before signing off. One assumes that telehealth can be used to be part of the 60-minute requirement in principal illness navigation. Is that correct?
Absolutely. Yes.
Okay.
Any of those service components for principal illness navigation could be carried out in person. A lot of the care management are actually behind the scenes, so they are not even interactive audio or visual communications directly with the patient. We might be coordinating care behind the scenes, but if you are live with the patient talking about their goals, their life story, their preferences, helping them navigate the system, developing a disease specific plan of care, if that's done via telehealth, that can count towards the 60 minutes as well.
Okay. And then I'm going to attempt to share. Can you see my slides?
Yes.
Okay, February 20th, Oklahoma Center for Rural Health. I will be presenting on evaluating telehealth services. While it is presented by the OSU Center for Rural Health, all are welcome to attend. February 21st, our consortium has their webinar series. Please be sure to sign up for that. It is a monthly series. We all share responsibilities for presenting. So go check that out. And then finally, we are having our Telehealth Everywhere conference. It is in Minneapolis again, part of our larger regional conference on May 21st and 22nd. So go to that website and check out that information as well. We will be sending out the slides recording, and then we will address every question in the chat box. Even though we may have answered it in real time, we will include it with an answer. That gives Richelle some time to pull resources as needed as well. So thank you all for your time.
Sorry, Molly, I was going to say, I'll make sure I pull the citations for any of those as well. So if you need to go back and find it in the final rule, I'll give you the page number where you can find it.
You always do a great job with that. So thank you. Everybody have a great week. Thank you for joining us, and we'll see you again soon.